and welcome to the 30th meeting of the Health and Sport Committee in 2019. We have received apologies this morning from David Torrens, MSP. Before we start the room, can I ask everyone in the meeting? Can I ask everyone in the room to make sure that mobile phones are off or on silent, and we will, of course, record and film proceedings, and therefore proceedings should be not recorded or filmed by anyone else. The first item on the agenda is consideration of subordinate legislation. We are considering today the Official Feed and Food Controls Miscellaneous Amendment Scotland Regulations 2019. The purpose of the legislation is to amend existing domestic food and feed law to provide for the execution and enforcement in Scotland of the food and feed elements of the new EU Official Controls Regulation and associated tertiary legislation. Do members have any comments on these regulations?
Convener,
Emma Harper.
Thank you, Convener. I'm interested in just confirming whether we're using this establishment of these statutory instruments to continue to protect our food standards across Scotland and the rest of the UK, including Europe. It's specifically the one that talks about feed sampling and analysis and specified undesirable substances, because I know I have concerns with the Food and Drug Administration's acceptable level of defects in food that comes from the United States. So I'm just curious whether this is going to continue to protect our food standards.
Sandra White.
Thank you very much, Convener. I understand it is a continuation, but there are some questions I did want to ask. Under the public consultation, they don't tell you who they consulted, and also you received 5 responses. So I think for clarity we should actually know who they put the consultation out to and who actually came back. Because when you go in to see what businesses are going to be affected, you've got slaughterhouses, cutting plants, fish auctions, wholesale fish markets, shellfish operators, milk and colostrum production. It's quite a huge, amount. So if possible, I'd quite like that. And the other issue that I raised was the fact that local authorities and others, the cost to them. But having looked at the full paper, I think it's something like £37, just over that, for the cost of local authorities. So I'm happy to support it, but I would quite like clarification on that, if possible.
I think a couple of questions there for clarification. The essence of these regulations is that they bring up to date existing European regulations as they apply in Scotland, and that's required at this stage because the United Kingdom did not leave the European Union at the end of October. These regulations come into force this month, and therefore the update was required in order to continue to be consistent with European regulations. In terms of the so in relation to your questions, Emma, I think it's fair to say that this does not change the robustness of regulation in this country in relation to any third party, because it maintains the existing European or maintains the European provisions that apply already. In terms of the points about consultation, separately from approving or not approving the regulations, we can certainly write to ask the Scottish Government to provide us with that information, and we can do that. Subject to those points, can I ask if the committee is agreed to make no recommendations in relation to these regulations?
Agreed.
That's agreed. Thank you very much, and we will write, as I've suggested, to the Scottish Government on that matter. The second item on the agenda this morning is to take evidence as part of the committee's ongoing scrutiny of NHS boards. We've heard from boards across Scotland. I'm delighted today to welcome the representatives of NHS Grampian and of the Health and Social Care Partnerships in the Grampian area. A welcome to Rona Atkinson, Vice Chair, to Adam Coldwells, Deputy Chief Executive, and to Alan Gray, Director of Finance of NHS Grampian, to Pamela Dudek, Chief Officer of Murray Health and Social Care Partnership, Sandra Ross, Chief Officer of Aberdeen City Health and Social Care Partnership, and Angie Wood, Chief Officer of Aberdeenshire Health and Social Care Partnership. Welcome to you all, and thank you very much for the comprehensive information you've provided in advance to the committee. Clearly, an ongoing issue and a concern for NHS Grampian has been around balancing the books and ensuring that savings are achieved, and you've laid out significant progress in that regard. I wonder if I can start by asking you what are the greatest challenges for NHS Grampian in achieving future savings?
Question, if that's okay, on behalf of the committee. I guess the single biggest challenge we probably laid out in our reports is our continued use of high volume agency locum and medical locum staff. So that's agency nursing and medical locum staff. We still have a number of shortages in key specialties, a number of challenges in terms of meeting our demand and capacity pressures, particularly around planned care. So going forward, that still remains a challenge. You'll see that through this year, that the use of these two sources of workforce have increased. However, we're taking some key steps to try and reduce that and to enter into a much more sustainable solution with our workforce going forward. So we've got a number of things running around, looking at our sourcing, recruitment, retention, training, development of staff to make sure we're maximising the pipeline of staff coming into the workforce. We've also embarked on a very hopefully a long-term strategic partnership with Western Australia to look at how we are able to attract nurses. They are overtraining nurses just now, and they are looking to offer opportunities for their nurses to take up posts in big teaching boards post-graduation, and we're seeing a number of these already starting to move across to fill key posts within Grampian. We'll welcome that, and we see it as a long-term strategic relationship that will hopefully allow us to recruit up to about 100 new nurses every single year. That probably double our graduate intake. That's about roughly what we get from the local universities within Aberdeen just now. So we see that as a really positive step forward. In terms of the medical staffing, we're kind of looking at all options around medical staffing. So part of the medical locum is to deal with the backlog around our waiting times, and you'll see the improvements we've made in that over the last financial year. We're starting to reduce that backlog, and we had 4,000 extra theatre sessions last year as a result. So some part of it is dealing with that demand capacity, but part of it is just dealing with long-term shortages in key areas like mental health, anaesthetics, emergency care. However, a number of things are probably going to help us. We've just recently been designated as the National Centre for ECMO within Grampian, and that's a real that combined with the trauma centre should make our whole emergency department a much more attractive proposition for us to be able to not only just train and retain the trainees we've got, but actually to bring in professionals from out with. And we're starting to see a bit of traction there, people expressing interest in joining our ED department as a result of us having these two major services being provided in Grampian regionally and nationally. So there are a number of things we're taking. I could go on for a bit more, but the workforce is probably the workforce cost pressure, probably the single biggest challenge that we face. Most other challenges we face are the similar cost pressures you see around most other boards. The cost of prescribing continues to go up, but we continue to manage that, I think, within resources. We do expect to continue to operate within our existing budgets and resources going forward, so that is our plan. We hope to remain that going forward.
Thank you very much. And following up on your reference to the major trauma centre, that's clearly now been in place for a year, and as you say, potentially has a significant impact on recruitment and retention. Is there evidence yet that impact is beginning to be felt in terms of the ability either to keep people or to attract people to come to the region? Adam Colgan.
Yeah, thank you, Camilla. I think that's difficult at the moment to draw a direct line of sight to that, but certainly the feedback from, it's a very large team who are involved in the trauma centre, and it spans right across the system. So the whole sense of people having long-term recovery into the community that's a part of a trauma centre. So there's a very positive vibe about it all. To be able to draw a direct line of sight and say, people are definitely staying, but it's a very, very positive action, particularly for patients as well, and the outcomes for people who suffer major trauma, to then have that very holistic and whole pathway of care that allows them to get excellent initial treatment, and as I say, right through to that recovery and return to normal living following good rehabilitation. So it's a very positive thing, and probably in a longer period of time we'll be able to draw more clearly the positive advantages, as Alan's described, for staff, retention and recruitment.
Thank you very much. Sandra White.
Thank you, Convener. Good morning, everyone. Thank you very much for the update in regarding the use of locums. Obviously, you mentioned that first in the agency nursings and older staff, and obviously your long-term strategy. You know, Australia, 100 new nurses. So I had a couple of questions, but I'll put them all into one, hopefully. Basically, you've said that's your strategy. I presume that the Australian one, 100 new nurses a year, I think you said. Yep. Basically, yeah, if you could maybe clarify that one. That will be one of your various initiatives. Is that the biggest initiative, or are there other?
A number of initiatives. Sorry.
No, on you go.
Sorry, I beg your pardon. There's a number of initiatives actually we are taking. So that's one. So we're also looking at things like physician associates, advanced nurse practitioners. We're looking at training a new type of operative to support or increase our capacity within theatre. So we're developing a training programme for that, and that'll create about 30 new posts every single year. We're creating a new wellbeing post, which is a post between a registered nurse and our current band 2 workers to really enhance our capacity in wards. So there are a number of initiatives we're taking to try and develop a broadening workforce in terms of developing new roles that people can, and career paths that people can follow, and also widening the existing new responsibilities, like physician associates, advanced nurse practitioners, which have clearly been in the system for quite a while. These are roles that can enhance, won't replace doctors, but we'll say they'll be able to enhance some of the roles that doctors previously would have done. Therefore, allowing the doctors to focus on those things that medics are trained for. So there are probably a number of things that we are doing in terms of developing and broadening our workforce and creating more opportunities for graduates and school leavers to come and join us. So that's our aim.
So, do you have I'm not saying an exact date, but can you tell us roughly when you expect it to kick in, and obviously the use of the agency nursing, locums, etc. would fall? Yeah,
well, I think we're seeing an improvement already. This year already, we're seeing that the vacancy numbers are starting to fall. So we're seeing a bit of a decrease this year in terms of the vacancy numbers. It's probably going to take 2 or 3 years to see the benefits. Some of these training programmes are going to take 2 years to complete. So it won't be 2 or 3 years before we actually see these operatives come into post and filling the new roles. So some are short-term. The Australian nurses are short-term. They're fully qualified and trained, and quite a rapid transition and entry into our system. But for some of other posts, it takes up to 2 years to train new physicians associates and advanced nurse practitioners, theatre operatives, wellbeing nurses. But it's part of a long-term strategy, so I think you hopefully see the benefit over time.
I mean, we're talking about long-term strategy. Obviously, you mentioned older workers, and I think that's a problem throughout, unfortunately, the health service. But if you're bringing more people in and training people up, basically, is that part of I presume, the initiative you've got in the future workforce planning in regards to the older workers, situation at the moment?
Yeah, I guess the age of the workforce is likely to increase. The pension age, of course, is now at 67, so the age of the workforce is generally going to increase. So it's actually part of it's how do we maintain opportunities for staff to work for as long as they're able to work. And for some that want to retire, can we bring them back into some? It's quite a lot of our staff do retire and return supplementary staffing on bank contracts, and that offers them some flexibility. It allows them to maintain professional skills and to use the skills they've got. So I think the ageing workforce is something that we're all having to use. It's an opportunity as much as a challenge, I think. We've got a lot of experience in that level of workforce, and it's making sure we can create a work environment and some flexibility that allows people to work for as long as they wish to do so. So I think the current cohort of people that could retire at 60, they'll start to move away. At 67 is a norm. So I think we need to think differently about how we extend the opportunities for the workforce over a broader now working age span.
I think just to add to what Alan's saying, we're concentrating a lot on things like we've got a scheme called My Healthy Workplace, which is trying to support staff to be able to continue to live healthily, which allows them to obviously work better and be able to enjoy your work, feel healthy in your work, feel fulfilled, all those things. So that's a real concentration across the system to see how we support people in work, because it's a real challenge. For some of our jobs are either very physical or require very fine motor skills, and through that ageing process we need to support people to age as well as we can. So across the country, it's a wide challenge.
Could I just pick up on that point, Convener? It's nice that you're looking positively, but a lot of people don't want to work or are unable to work to the 67, basically. Unfortunately, in this particular day and age, they're being made to work to that time. When you talk about the initiatives and bringing the new nurses and the well-being, etc., it appears to me that you're assuming, and I don't mean this in a bad way, that you're assuming that the people who are working in older workforce are going to be working on to the 67. Is that the take? Have I got the right take on that particular one? You're not assuming that people, because of the heavy workload, which is true with nurses, etc., lifting people, are going to not return to work? You're assuming they are going to work to the 67 then? You're not...
That's our national retirement age, and that's the scheme in the NHS is a retirement age of 67. So we have some assumptions around that. We're towards the tail end, I think, of the change between the old scheme and the new scheme. So I think people in their mid-50s are probably still on the old scheme with a retirement age of 60. But everyone else, the new scheme that was the 2015 scheme has a designated retirement age of 67. So if you finish early, you obviously have an actual reduction. So again, that trade-off of time and money will be in people's consideration. So they'll have the right to retire, obviously, but it will be at a cost to the resource you have available to you in your retirement.
Sorry, Chair, thank you. It just seems to me that whilst the initiative you're looking at, and I applaud you on that, about Australia and well-being, etc., but in your workforce planning, you are basing it on the fact that people will continue to work to their 67, and that kind of skews the figures a wee bit, I think.
Sorry, I'm not sure I quite understood what you meant first time. Apologies if I didn't quite answer. So I think the change in the age is part of our trying to mature the workforce planning as we go forward to see at what age people do stop working. And again, I think it will vary across all sorts of roles, and it might be interesting to get a perspective, if that's right, convener, from some of our health and social care partnerships about, again, their workforce, a very heavy workload for some of our care workers, for example, across that spectrum. So I think it's quite early for us to have that whole model of how people actually behave against the new retirement age and the new pension scheme. So I think that's work in progress for us and understanding.
Thank you very much.
I think just to kind of add to that, it's when you get out into the community, there's obviously a lot of varied roles that can support people to stay well, and we actually do have a profile in Grampian of a fairly healthy older population, and my experience of working with communities, and I'm sure it's the same with my colleagues, is that lots of people do want to be active in that. At what level is what we need to understand, and to what proportion. So part-time opportunities do seem to attract some of our, the idea of having purpose in your day and still being able to contribute seems to be very important to people. And I guess it's us optimising that by considering the roles where that's possible. And the other area that we've had, which isn't employment, is a lot of success in volunteering. And the volunteering initiative that we have in Murray has at the moment a sort of stable volunteer base of about 250 people, and over the period of time that's been run in the last few years, we've had about 550 people through that. The oldest one at the moment is 92-year-old who does buddying and dealing with the kind of loneliness aspect. The youngest is 17. So yeah, I think we probably are trying to think in much more creative and understand better roles that are beyond the traditional roles. And again, I could probably talk about that for quite some time, but I think that has to be part of the answer.
Thank you very much. And did you have a final?
Yeah, I did basically. I was interested in the regional working. I think you've touched on it, throughout the north of Scotland, because I seem to recall when we took evidence from the hospitals at Carlisle, etc., Carluke, they had quite difficulties bringing people forward to live there in the area. Do you have a problem with that in the region overall? For people to, workers to come in?
Regional work.
Yeah.
Yes, I have, sorry. Yeah.
Shall I start off, if that's okay, and then perhaps get a perspective from some different people? So I think we have a bigger system, so it seems to be that the further you get away from the very big city, so the central belt, I think we definitely have more of a challenge in recruitment, pretty much across the field of professions. And certainly within a Grampian context, we absolutely see a relationship between distance from a city. So when you get up to the outer regions of Aberdeenshire, it's 10 times harder to recruit doctors and social workers than it is in the middle of the city. but the city still has quite a challenge next to Edinburgh, Glasgow. So I think there's some definite micro relationship and then a more macro one across the country that we definitely observe.
And I think I would add to that, the chief executives across the north of Scotland have got some very strong conversations going on at the moment, because we're recognising that there is a supply issue across a great many of the skills that we're looking for. And there's also what we're trying to do through the trauma centre is if you make the jobs more interesting, people will stay. If they get more interesting work, there's a logic to that. So there are very strong conversations going on that say cross-boundary working is something that we have to make work. It is good for the patients, it's good for families, and it's good for people living in the area, and the attraction rate goes up. So those conversations, very early days, but certainly there's support across all the boards that are involved in those conversations.
Thank you very much. And there was a supplementary from David Stewart.
Thank you, Commissioner. Could I raise just one very specific point that I've raised several times in this committee, and that's my general concern about UK Treasury rules over pensions. It's been raised by BMA, it's been raised in the British Medical Journal almost weekly. You'll know that Department of Health in England looked at this, and there was some plaster put on this, and I've certainly raised this with the Cabinet Secretary, and there's been some work there. It particularly affects doctors, although any member staff, particularly in final salary, could be affected. What's the effect been on NHS Grampian as far as retention? And one of the key points isn't so much probably retention, but it's full-time working, because my experience is it's post-55 consultants the problem starts becoming and hitting home. Is that your experience in NHS Grampian?
If I start, and maybe Alan could follow if that's right, convener. Yeah, so the anecdote is absolutely staggering. I'm of a similar age, grew up with lots of these sort of folks, and when I meet them, and I've known them, worked with them for 25 years, that's a common conversation at the moment. Just yesterday, even a GP, so it's not just hospital-based doctors. It's absolutely challenging. The GP regulation is even stricter because they're self-employed than the bit of sticky plaster we put on recently in Scotland. So I think Alan's been doing a bit of work and might have some more evidence-based stuff, but it's a really live issue for people, and it's lots of the bit about people being able to predict what's going to happen that's really putting them off as well. And if I go back to primary care and general practice, because they're 2 years in arrears, the way they do their accounting, it's caught all sorts of GPs absolutely just caught them out. I don't know about a better description than that. So I think it's a real risk, and if there are things that we can do within the country, I think that would be extremely valuable to prevent all the worry we've heard through as you say, through the BMJ and such like. So.
If I could come in, and I think the difficulty with it has been that it's crept up on staff, because initially the lifetime allowance was quite a high level, and in fairness, since I'm always fair, this has been successive governments have looked at this as being a great boost to the Treasury, and it's now down, last time I looked, at 1.03 million, which sounds a lot, but if you're in a final salary scheme and you're a consultant, you can easily pick that up by your mid-50s. So my concern for management is you can say, I know how many medical students I'm going to have graduating in year one, and if you add 40 years, they will be full-time equivalent. Well, they won't be full-time equivalent, because by the time they're in their 50s, they're looking, if they've got decent financial advisors, saying you're mad working full-time because you're going to have this huge tax hit. So it seems to me a perverse consequence. I understand why Treasury are doing this, but what's the point of doing it with one hand, while the other hand you're trying to invest in the NHS? It makes no sense at all.
Say, I actually would hit them much earlier than the 55s. Consultants, early 30s, they'll be hitting the lifetime allowances in their 40s, early or late 40s, I would have thought. It's affecting them in terms of, we don't know yet what decisions they'll make, but it's certainly affecting their decision of when they'll retire and leave the service. So some are thinking about and planning now about, when they're likely to leave the service, let alone retire. Where we're seeing it most immediately is people are still picking up waiting list initiatives. They're doing their core 10 PAs, but additional sessions beyond their core 10 PA contract, they're dropping, and quite a lot of them are dropping the additional sessions. So we are losing capacity because it's just not worthwhile, because you're getting hit already in tax, because you're getting hit already in a premium, you're exceeding your annual allowances, and you're getting hit quite heavily. So there's really no incentive to take on additional sessions, which are absolutely essential for providing patient care. So the effects are a multitude. I think career planning for doctors and medics generally is going to change radically. This is just something that's come out of the, as you say, come out of the blue, I guess, and we haven't really planned for it. And it's hit us in a way we hadn't expected. I think it will have a pretty detrimental effect over the short to medium term as doctors, because they have options and they have alternative ways to occupy their careers and their skills. So it's a great question. I think it's something you've got to keep an eye on.
Sure.
And I welcome your committee's interest in it, so thank you.
The other thing that's happening in Grampian is our pensions manager has done a great deal of work in explaining what the actual implications and what mitigation consultants and nurses have if they're approaching the lifetime allowance. Not to give them guidance, but to make them better prepared to put them out to speak to financial advisors, because there is a knee-jerk reaction that it looks negative and they walk away, but it's allowing them to find some space to work through and to plan what's the best route for them forward, and that's given us a bit of leeway as well.
Okay, thank you very much. Miles Briggs.
Thank you, Convener, and good morning to the panel. I wanted to ask a few questions, firstly on financial management, and wanted to ask around the NRAC funding formula, because I know here in Parliament colleagues from across the political spectrum often raise NHS Grampian over 20 years being underfunded, and just wondered what your view of NRAC has been over this period of time and whether or not you do believe it disadvantages NHS Grampian.
I'm working very close to the Scottish Government since I was appointed 8 years ago, Miles, to try and address the gap we had, because the gap in Grampian has, we weren't at the formula, as you know. I'm pleased to say that over the last 8 years we've made good steps towards being at the NRAC formula. So I guess we're now within 8% of the NRAC formula. So I recognise there's been a history of challenge for the Grampian board. Throughout that period we did balance the financial position, so we did operate within the resources we were allocated. I'm very pleased to say now that we are much closer to that NRAC formula. I guess the residual challenge that NHS Grampian will face, probably one other board in Scotland faces the same challenges around the population share is about 11%. At the NRAC formula, our share of the allocation is 9.9%. So it's a 1.1% differential when most boards are largely funded at a population level NRAC formula. £1.1 million translates to quite a large sum when you allocate £9 billion of NHS resource every year. So that's the one thing that remains still a bit of a challenge for us. The per capita funding that we get is going to be somewhat less than most boards in Scotland. However, I'm very pleased to say, I'm pleased that the commitment was given to get us to the NRAC formula. It's been really great. It's allowed us to invest quite significantly in services. We've seen the benefit of that. So I'm pleased where we've got to with that, and I think I'd welcome an open mind around the fact that we still have a per capita level funding that is a bit more challenging compared to most of the large teaching boards in Scotland. But we'll work on that. We've got a good stock links with the Scottish Health Directorate. They understand the challenge and they're keen to look at that with us to see whether indeed the health need of Grampian is so much less than the rest of Scotland.
Did anyone else have a point they wanted to make? In terms of service performance then, I wanted to move across to cancer performance, because the stats out today from ISD have outlined a slight improvement across Scotland in terms of the 60-day treatment for cancer. Not the case in Grampian, where there's been a decline to 79.7% from 86.8% in June. And so I just wondered what the reason was behind that.
We're dealing with the backlogs. As soon as we treat patients who've been waiting longer, we are breaching the target for those patients. So part of it is addressing the backlog, and we'd expect the performance to dip slightly as we eat into that backlog and reduce that backlog of patients. We still face challenges around two particular cancer types, urology and colorectal. We are putting additional capacity around all stages of the pathway, from diagnostic through to treatment, over the next 3 months to try and further eat into that backlog. So yes, I accept the performance is not where we'd like it to be. Part of it is addressing the backlog. We are seeing more patients now, and I'm hoping that over if you're here in a year's time, you'd hopefully be able to say that we have made some significant progress towards achieving both the 62 and the 31-day target. It's something that's a priority for the board, so it's something we are sighted on. We need to do better on, and we have plans in place to address the capacity gaps we have. Most of these are short-term solutions. But going back to the earlier question we're asking around, we do have a plan to try and increase our capacity across all the major areas, from the diagnostic, the one-stop facility, so we can get people in diagnosed without multiple visits, and then get them onto a treatment path, radiotherapy, chemotherapy or surgery, whatever is required.
And would you say that's partly mostly down to workforce challenge then, or the equipment, or what's the rationale around?
There's a little bit of diagnostic equipment, so we have got an additional MRI capacity on a temporary basis, so that's addressing that particular issue. Most of it's staffing. We've got quite a lot of vulnerabilities across pathways where we've got single practitioners where the service is dependent, or some parts of the pathway are dependent on single practitioners. And we're trying to address that by putting some resilience into these areas. But that takes a bit of time in terms of recruiting, training, and then embedding these within the pathway.
Thank you.
Emma Harper.
Thank you. I'm interested in some waiting times information. So in our briefing papers it says NHS Grampian received an additional funding from the Scottish Government through the Waiting Times Improvement Plan, and the funding was intended to support health boards to improve waiting times across a range of services, including cancer and diagnostics, which we've just touched on. And it also notes that there's a number of treatment time guarantee patients were waiting over 7 to 8 weeks. That was an increase in the trajectory from early 2018 and peaked in April 2019 at about 450 people. So, but it seems to be going down in numbers now, and that's good news, I suppose. So I'm interested to know how the additional funding is being used to tackle waiting times.
To answer that question, if that's okay, too, from part of my remit as well. So, in terms of the money, we got about £12.8 million allocated to us as part of our Waiting Times Improvement Plan. So, part of that is we're investing in what we call recurring capacity. So, the very question that was asked a second ago by Miles around your building capacity. So, about £5 million of that money has been invested in recurring capacity across a number of specialties. So, that's building resilience into our system. And the remaining part has been built, we're using to bring in additional capacity through a range of private sector contracts we've got, and they're providing capacity in areas like Dr Gray's, Strathcathro, where we're looking to maximise the availability of theatre we've got within the area, as well as providing additional capacity within the ARI site. So about 7 million, or just short of that, just above that, is spent on the independent sector. In terms of performance, I've got just a couple of numbers that you've probably got in your packs. So at the start of the year, in January, with just short of 16,000 patients waiting in an outpatient waiting list beyond their treatment time guarantee. That's now down to 8,500 as of the most recent reports we got last week. In terms of the patients waiting over 26 weeks in outpatients, it was 5,200 at the start of the calendar year. That's now down to 2,500 as we speak. So almost a 50% reduction in those patients waiting over 26 weeks, and almost a 50% reduction in the overall outpatient list. So I think that shows in terms of the progress we made around that. In terms of the inpatient care, we're just short of 6,000 patients at the beginning of the year. The most recent position is we've got 4,000 patients waiting. So we've still got a large number of patients waiting, but a significant improvement from the beginning of the year. So if you look at the trajectory, it's a steady decrease month on month that we're hoping to continue to make progress on through the next stage of the Waiting Times programme, a copy of which I think was submitted as part of the evidence for today. So we do welcome the money. I think I can give you the absolute guarantee every single penny of that money is going to additional capacity, and you've seen that being really helping us improve our performance. And I said earlier, we've had 4,000 more people in our theatres this year than last year, and I think that's great in terms of 4,000 more people treated, as well as a number of people being treated on time, or more people treated on time as well. So I think it's been hopefully money well used and well invested, and hopefully you'll continue to hear about that trajectory coming down.
I mean, I know there's challenges with when people are on a waiting list and our increasing our elderly population, so that means more people will need hip replacements, knee replacements, and to prepare patients for surgery, we have to make sure their clotting time, their coagulation, their warfarin levels are all within a limit that's going to provide them a safe surgery and then an optimal recovery. And I say this as a nurse, that I understand how we prepare patients for surgery. So the persons who are on a waiting list for total hip, total knee, having their gallbladder removed or whatever, if they aren't meeting the safe surgical parameters, they will still remain on the list though, and that sometimes maybe skew the numbers and make it look like patients are waiting longer, and it's because they're not necessarily fit for their surgery yet.
In other words, do the numbers that you have here, do they reflect exclusion of people who are not fit for surgery, for example? Adam Coldwell.
Yeah, happy to answer that. So, so that we follow the rules set out by the government in terms of people's clocks starting and stopping around availability to be treated. So if someone comes to pre-surgery and they need to lose weight, would be perhaps one of the most common ones for people to be fit for anaesthetic, then their clock stops while they are addressing that. And then they come back on with the clock started at the right time, just absolutely in line with the rules that are set out for everyone who's a resident in Scotland.
Okay.
And I know that we're getting better at screening patients for bowel and breast and cervical cancer, so if we're screening more people, then that obviously puts challenges on then the whole pathway or the process for supporting people for chemo, surgery or radiotherapy as well.
Yeah, I think the screening programs are good, fundamentally a good thing to do. When you get the screening you get promotions, people are encouraged to go along to their doctors if they, or to use the bill screening. I think they do create a bit of capacity in the system, but that's for us to manage. So I think the screening programs themselves are a good thing. Early diagnosis ends up in much better outcomes for patients and much better health longer term. So I think these are good programs. We just have to find a way of being able to manage the fluxes in capacity that these generate. But I think encouraging people to be screened, to get checkups as appropriate, are definitely the right things to do, because we do identify things much earlier, and if you can intervene much earlier, the outcomes are so much better. Just in terms of just to reassure, in terms of the clinical patients waiting on an inpatient waiting list, every single one of these patients has been risk assessed. So we have risk assessment. We have a system in Grampian that risks assess every single one of these patients and puts them into one of three categories. Patients that really have to be seen within a 1 month or 8 week window. So those patients that do require urgent access to inpatient care are properly prioritised within our system. And those patients are on the list. Everyone's evaluated and continues to be evaluated, and their conditions change. They're asked to be referred back into the consultant or go back to their GP. So we don't wait and hope that people, we actually actively monitor people on a waiting list to ensure that we are making sure that we're doing what we can, and if things change, that we're able to respond to that as required. So.
And I'm assuming you'll be continually assessing to look at the downward trajectory of waiting times to make sure that the government's support is being achieved.
Absolutely, we want fewer people to waiting long waits. It's not a good thing for anybody. So the quicker access we can provide, the better. So I think the current position around over 7 to 8 weeks, we're now down to about 100 now, and in a couple of specialties. So there's a couple of specialties, and we're providing additional capacity within Dr. Gray's and Strathcathro Hospital to try and deal with these long waits over the next 6 months. So that number's coming down. There's still more than we would like, but a significant improvement where we were at the beginning of the year.
So instead of 450 people waiting more than 7 to 8 weeks, it's now down to 150.
I think the exact numbers. I had the exact numbers. Yeah, it's about just over 100, I think, if the numbers I had this morning. But,
okay.
Yeah, so it's a lot better, significantly better.
Okay.
On all fronts.
Right, thank you.
So thank you, and thanks for the question.
Thank you very much. And now Sandra White on delayed discharge.
Thank you very much, Convener. I wanted to ask about delayed discharge, and it is a huge issue throughout all of the areas of health boards. And I'll combine the two questions that I had. October this year, there were 3,470 beds which were occupied through delayed discharge. And then in September of this year, performance report to the board noted that the health and social care partnerships were introducing additional efforts to reduce patients being delayed in hospital. So my two questions are, what are the main drivers behind the delayed discharge, and what steps are being taken by the IGBs to reduce the delayed discharge? So I'll fire it open to yourselves then.
Who wants to start?
I can start. Yeah, I can start. So I suppose the key driver, you're asking what's the key drivers for delayed discharges, the main areas for people staying in hospital. I think a lot of that, our key areas are down to placement within the community, so it would be either care at home or a suitable destination, care homes, different areas for them to be able to be supported to go home. So across the whole system, we have looked at that in regards to our delayed discharges, to look at what we can do to help people get home, if you like. There's a number of areas that we've looked at. We've looked at assess discharge to assess, which means that we're helping people to get out of hospital a lot sooner, especially if they already have care packages that are in place. We've worked with our housing colleagues across across the partnerships as well, to see if we can utilise sheltered and very sheltered accommodation to help some supported hospital discharges beds there as well. We've looked at areas, we're working with our inpatient, with the acute services to say, to make better use of OT, better use of care management, to do some in-reach work in there.
Yeah. Okay. I think it's probably important to highlight that overall our performance in Grampian tends to be below the Scottish average, but obviously we still have a number of people that are delayed, and we're looking to minimise that number. I think it's a very complex system, and it's actually something that we really pretty much on a daily basis have a lot of focus around, because the whole system contributes to how good, bad or indifferent that number is. So it's not the availability of care is a big issue for all of us, and that again relates to workforce. So social care workforce and home care workforce is a challenge for us right across the system, and quite a hot topic for us at the moment. But I think it would be remiss not to acknowledge that even in hospital, in terms of how we've historically worked and how we need to work and how we work with families, and everybody understanding the importance of getting someone through that hospital system and home and maintaining their independence is an ongoing conversation. There is still quite a strong belief, and again, when you spend time with communities, which you all do, that hospital is the best place for people, and actually that's not the message that we're trying to put out there. But we are still working on those relationships and people understanding what that means for them as individuals and as families. And I think across the patch we work very closely together as three chief officers with the chief officer of the acute sector, and so every week we meet, and this is probably one of our main topics, to say where are we at, what else can we do, how else can we get people together to come up with new ideas. So I think that's positive, and sometimes you see a huge impact of that, and then other times you can see that stabilise a little bit and be a challenge for us. So it's just there's multiple efforts around this. What I could say from a Murray perspective, we have got quite a number of housing initiatives, which are extra care housing, a partnership with Hanover, and certainly our usage of care homes is pretty static. We do not have a rising requirement because people are seem able to stay in their homes and stay independent because they have the right environments. But we definitely continue to have a real challenge around workforce and home care, and that can be the rate limiting factor.
Just for clarity, the point you made at the outset of your remarks is that the performance of Grampian on delayed discharges is better than the Scottish average, and that would be true for all three IJBs. Angie Wood, would you like to?
So within Aberdeenshire, I think similar to both my city colleagues and Murray colleagues, delayed discharge is an issue we speak about often, and certainly at the IJB we've been really supported to really try to understand what the people are behind those numbers. I think increasingly we're seeing that hospital is maybe not the right place to make decisions about what your future provision is going to be. So we're working really closely across the three partnerships and the acute sector to see how we can get people home to then be able to make those decisions, because often the trauma of being in an acute centre is not the right place for that decision. So within Aberdeenshire we've always got a bit of an issue around distance and just getting people in touch with their local teams. So again, working really closely with the acute sector to have care management, to have AHP input into the acute sector so that we can start those assessments well in the acute sector, but maybe support people back home, even if actually that isn't going to be an ongoing basis for them, but just so they're not having to make that decision within that environment.
Sandra Ross.
I suppose, sorry, just to really, it would be remiss really not to say that although delayed discharges is a large focus for us, I think across the whole system, one of the other areas that we're particularly focused on is prevention of admissions, because what we do understand is that to stop our delayed discharges, that people are supported to be at home longer. So we have our, each of us have a variation on the hospital at home theme. We're supporting admissions, working to prevent admissions coming in, working with our primary care colleagues as well as secondary care and as well as our whole system to really look at how we can prevent people coming into hospital. This winter planning we have a really large marketing campaign on Know Who to Turn To, and again that's about redirecting, using all the resources that we have both from Scottish Government and locally to really divert people away from hospital, and that way we can help support them.
Thank you Very much. I'm glad you mentioned that, Sandra, at the end there, because what certainly I find, not just in your own area, but in other areas as well, is the lack of joined up working more than anything else. You mentioned, obviously, a delayed discharge and a package, but on a number of occasions, the package isn't there. And I just wonder, do you get referred back from the doctor or the occupational therapist? Can you track a patient? Do you find out once a patient has supposedly got a care package in place and then they're discharged and the care package isn't there? Do you know about that? Because what I find, constituents, some constituents are back into hospital after having been discharged and they're back in again fairly quickly because there's no package there. And I just wonder how joined up, and I know you've got a huge area compared to obviously my area in Glasgow, Kelvin. So how does that work for yourselves?
Can I make a contextual remark and then perhaps ask Angie and the others to do it? So one of the things we're really, really proud of is how well we've grasped the integration bit. So we have really, really strong relationships between Grampian Health Board and the 3 council areas, City, Shire and Murray councils. And we've spent 5 years developing what we believe is a really fantastic integration model for the northeast of Scotland. We believe we've developed that with a real sense of localism alongside it. So there are differences in Murray, City and Shire, but just really appropriate differences for different populations, of which they are really quite different. So that's one of the things. So again, in the pack, you will have seen our response to the ministerial strategic group about integration, and we felt we had a really mature and realistic self-assessment of that, with things that we need to do together to make it really good, as well as stuff that we absolutely think we do well. And part of that's been at the board. So the board had a report on all of our reflections in October of this year, and that's a really cohesive improvement plan for each one individually, as well as the institutions that then work in partnership together. So there's a sense of we hope we leave you with a message after today that actually we think we've kind of got the hang of this integration thing. And if that's okay, convener, if I could pass to one of them to describe your exact question about tracking patients and integrated teams, that would be fab.
I'm happy to. Yeah. So yes would be the answer. There's and I can kind of give you almost a daily example of when I do get a query and my team are immediately able to come back and say yes, they know that person and it's in hand, which is reassuring. And sometimes the story that comes in isn't actually completely in line with what we find when the information comes back. But we also, our teams, and Murray's not big, so it's not difficult to join your teams up, and they've got a history of working in quite an integrated way. But with Dr Gray's, where our unscheduled care in Murray is pretty much contained in Murray, so the teams meet on a regular basis. There are daily huddles, so absolutely are able to track and pick up.
Sandra Ross?
Yeah. I would just echo what Pam's saying. Yeah, absolutely. We have within City, we do have our care managers and our social work areas. The discharge coordinators are based within acute, so there's daily that's happening about who's going where. But if somebody does go home and there is a possibly not at the right time that they would look for, or maybe not the full package, but they're going home, they remain on a list. So we constantly monitor that and have that list monitored. So yeah. Okay.
Angie Wood, I don't know if you want to try anything.
I think just to build on what my colleagues have said, but I mean, I think to give assurance that the way that the partnerships work with the acute sector, you know, that there is this daily huddle. So actually, you know, I don't think I think we've got much better at not feeling a patient goes into the acute sector and therefore they're not the community responsibility anymore. I think they absolutely are, and we do share that information, and we do try to think about what does that patient need, not just today, but actually what are they going to need in 3, 4, 5 days, so that we can start to get ahead of that and to be able to plan it much better. But I think the beauty of the integrated services that we have is that, you know, if a care package isn't delivered, then that still sits at my door. It sits at all of our doors, so therefore it is in all of our intention to make sure that happens well.
Okay.
The chair, we I've read the notes, but I just wanted it on the record because not everyone reads the notes, so it's good. Thank you.
Thank you very much. Alec Cole-Hamilton.
Thank you very much, Convener. I too would like to talk about waiting times, particularly as regards child and adolescent mental health. As of the quarter ending June 2019, very nearly half of all patients were seen beyond the 18 weeks. I'd like to come back to that in detail in a minute. But first, for the benefit of the committee, I'd like to understand the landscape for child and adolescent mental health in Grampian, particularly around Tier 4. I mean, I know at the start of this Parliament there were no Tier 4 beds out north of Dundee. So I just wanted to get a picture as to what you do when children need inpatient psychiatric care.
Yeah, generally, our experience is that we seldom admit to a residential or inpatient care facility for any of our children currently. We have the facility in Dundee. I don't have the exact numbers, so I can't give you the exact numbers, but I know the numbers are very, very low in terms of us requiring to admit. Our model is very much about supporting patients to stay in Grampian with appropriate professionals and others around them. So our aim is not to admit, because admission takes people away, Dundee takes people away from their family. The distance, it's not a good outcome in terms of that. For short-term admissions, it's probably appropriate. It's something that we don't see the need to develop something in Grampian just now, currently, based on the current activity. I can tell you a little bit about what we've done in terms of redesign. We have fundamentally redesigned. You do reference the fact that in June we did a major redesign of our CAMS service. So we now have in place a 0 to 18 service that covers all children from 0 to 18. There's no transitions within that service. We've now co-located all our Aberdeenshire and Aberdeen City services in one purpose-built centre in the city of Aberdeen, and that's gone down really well. That opened in July, and that's allowed us to actually create about 24% additional capacity because people don't have to travel. It's allowed us to basically put all the professionals into one area. So the feedback from carers and from patients is they're coming to one place that's much more accessible. It doesn't feel like a big hospital, and it feels like something that's got the person in mind that's coming for a bit of care and support. When the patient's there for their assessment, they can be seen by multiple professionals on that day because they're all in the one place. So it's not as if we're having to refer them to multiple professionals to get an assessment. They can get the assessment in one day and then put on a treatment package very, very quickly. So we've done that in terms of that. That's.
Can I just come in on that? Thank you. No, I mean, that sounds very gratifying, and it's clearly a rationalisation and makes a lot of sense. In terms of the waiting times themselves, though, are you seeing an empirical change in those?
The position I've got, the management information I've got at the end of October was we're now at 71% in terms of patients seen within the guarantee, so time, or within the 90% time. So we're aiming to get 90% by the end of this next calendar year. So a year from now, we're aiming to be at the 90% target. We're confident we can do that. The other thing we had in Grampian was a CAPA model, so it's a different model of so that's a two-stage assessment. So basically, patients would be given a very comprehensive assessment by a multidisciplinary team. But that wouldn't count in terms of the waiting times. The waiting times would only count once you started at the next stage, which would be the treatment stage. So what we've been doing is working with the guidelines to look at actually how do we get recognition for that first assessment, which actually does start treatment, because it does actually signpost people to immediate opportunities for support and help there and then. So for all of our patients, they were seen within 6 to 8 weeks. That first assessment would be happening within 6 to 8 weeks. So people weren't waiting long times to be seen. I guess the waiting times, the way they're measured, it presents a picture that people are waiting a long time to be seen for professionals. They weren't. The bit between assessment and treatment, we're trying to address that gap. So that gap is now between 6 and 8 weeks between assessment and treatment. Certainly along our muddy area, we've got 1 or 2 challenges around capacity, but we're addressing that. So I think hopefully by this calendar year, you'll see a significant improvement in terms of our performance. More children are being seen, assessed and given the first stage of treatment within that time period. So I think we're in a much better place than we were some 12 months ago.
Really just to again add to that, I mean obviously in Murray there is still work to be done and that is progressing and there's a confidence around the improvements there getting to the right place. But I suppose I can never help myself but saying that CAMS is an endpoint, and actually the outcomes for our children in terms of the resilience and early intervention and prevention is absolutely where we need to be focused. And in Murray, we've had quite a journey around children's services in terms of a poor inspection through to making good progress at the beginning of last year and being in a good place where we were described as knowing ourselves and knowing what else we needed to do. The big focus now is that we have new integrated children's services plan due for publication across all three areas for the 1st of April, and the priority there certainly in Murray is wellbeing, mental health and wellbeing, and we have been doing quite a lot of work around that. We are involved in the Real-Line Children's Services National Collaborative Improvement Programme. We have just in the process of completing our strategic needs assessment, which has given us a very clear indicator as to what we need to do, and we've also looked outwards to areas who are doing well in this arena, and that seems to follow a pattern of, not surprisingly, integrated teams sitting around school catchments and taking the stress and distress out of the schools, and therefore supporting children and families in their well-being. And I think we've had a real eye-opener by being able to embrace the voice of children and their families through that programme and really understand what it is we're trying to respond to, because many families would benefit well from that early intervention and would probably never need to go near CAMHS.
Well, that's good to hear. Thank you, Convener. I think it's great to hear that you're seeking to take the stress and distress out of schools, and we know that access to talking therapists as soon as possible, as soon as young people start to feel unwell, is the best way of preventing them to need to enter CAMHS in the first place. Would you say that children in schools in the area have universal access to that kind of provision, or is it on a patchy basis?
I would say that's still variable, certainly in my patch, and that's the ambition through the new plan, is that we address that with our multiple resources in a joint commissioning way. So again, we really have integration at the heart of this, including third sector and our local resources.
But that's your aim,
yeah,
to have everybody having that early access to talking therapists. Okay. Thank you, Convener.
Thank you very much. One of the other issues that was raised when we consulted the public on the provision of services in NHS Grampian was around psychological therapy services in primary care, specifically in Murray, and specifically in the sense that it's being enabled by Scottish Government funding across Scotland, but there appears to be a particular issue in Murray. I wonder if we could understand that better, please.
I don't know, clearly understand all the background to what the queries are, but from a kind of general mental health approach in Murray, we have had we're in year 4 of our strategy.
Sorry, for clarification, this is in relation to psychological therapy in primary care?
In primary care, yeah. So through our primary care improvement plans, we have got the Action 15 money, which we have joined up with the funding that we have for the broader interventions, and there are a number of initiatives underway, both commissioned and within the surgery. So the provision of link workers, the provision of distress brief intervention, we're part of the National Improvement Programme with Penumbra, and the SAMH locally, we have a wellbeing centre that does a number of interventions which is linked to primary care. So this is part of a pathway of care. It's not that everything sits within the GP surgery, if you like, but the link is with the GP surgery to provide a response to people, again, who are have stress and distress in adulthood. We also have a particular focus around young males, an initiative again around that because of the kind of prevalence of young men taking their life, and that initiative is right across Murray. So we have quite a number of interventions at that stage that are not GP led, they are the wider system led, and an integrated approach to that. There is also a social movement known as the Wellbeing Hub that has a number of peer people with lived experience who are champions across Murray and delivering cognitive behavioural therapy based approaches in local community centres. So it would be probably useful to know some of the specifics, maybe obviously not in this arena, to see if we can respond positively to that, but we are absolutely taking quite a number of actions.
Certainly the suggestion suggestion was that the psychological therapy provision within the primary care, the specific unit in Murray, was being closed down while they were expanding elsewhere in the country.
No, that's not the case.
Okay, thank you very much. I wonder if I can ask for Aberdeen, Aberdeenshire, and we've heard a bit about Murray and the access to therapy in schools and other points about the ability of young people to access mental health and wellbeing services, if there are compatible things in Aberdeen, Aberdeenshire. And you would.
So I think one of the major benefits of integration has been not just around health and social care, but our ability to integrate more widely across other NHS systems and indeed other council systems. So certainly within Aberdeenshire, although the IGB doesn't have responsibility or delegated responsibility for children's services, we have really strong and developing relationships with our colleagues in education and children's services. So certainly there's a number of pieces of work that we're hoping to take forward to try and really join up services so that schools and the young people at those schools feel more supported. I think that's possibly more important for ourselves as a rural area, but actually it's really important that people feel integrated within their own communities and can identify to those supports within their communities as well. So absolutely, I think the increase in resources around CAMHS and the changes there have been of benefit across Aberdeenshire. It's how do we work on that very local level to make young people and their families feel supported within their own communities, and how can we work differently with education so that we can think about what different could look like.
Thank you very much. Sandra Ross.
Hi. Thanks. I would just really probably echo exactly Pam and Angie's feedback, just to say, yeah, we're working strongly with education, trying to make sure that we have good support, the ambition being that we have equity of service across the whole of the city. With regards to psychology, we also have that available in primary care, and also have moved forward with our link workers as well, which again helps our level tier 1 and tier 2. So we have link workers in every one of our GP practices, which gives early intervention and gives really positive signposts and helps people move forward that way. So really just to echo what my two colleagues have said.
Okay, thank you very much. David Stewart.
Thank you, Convener. Could I talk about services in Murray, particularly Dr. Gray's, and I'd refer the panel to the NHS Grampian public consultation feedback. Could I just quote from 4 separate consultees who said some interesting things about services? The first said, the current situation of staff shortages and the abysmal state of maternity services smacks of utter contempt of Murray patients by NHS management based in Aberdeen. The second said, and why does Murray / Dr. Gray's get such a bad deal? The third said, Dr. Gray's is very much treated as a poor relative by Aberdeen management. The disregard for Murray patients is patiently obvious to anyone living in Murray. And the fourth said, whilst acknowledging and thankful for the caring staff at Dr. Gray's, surely it's time to address the fact that we do not have a hospital capable of serving the needs of residents. Surely it's clear to everyone surely it's clear to everyone when anyone from a baby to an elderly person is forced to travel to Aberdeen to access clinics, treatments, operations, procedures, etc. Politicians must admit that money is not served well and deserves better. These are obviously 4 separate individuals. Clearly they're being quite critical about that situation, and I would really like the panel's view on service provision, particularly in Dr. Gray's in Murray.
Would that be right, if I just start to set the context of how we work and how we include Murray, and then Pam, who leads there, will follow, if that's okay.
Sure.
So, for those that aren't familiar with our Murray's, Elgin's about 70 miles north of Aberdeen. It sits within the Murray area, and as Pam described in one of her earlier answers, Murray works as a really well-contained DGH and has tremendous relationships with primary and community care. So for lots of people, it's a really holistic system that manages their condition and illness, locally, absolutely as you'd want. We have a joined-up system leadership team, of which Pam is a member. And over recent time, Pam has taken on a leadership role for all of Murray, so including Dr. Gray's Hospital, although lots of the acute parts of waiting times are still supported from Aberdeen, again, to be part of a holistic pathway of care for people on a waiting list. So as a system, we have a really clear view of Murray is absolutely part of our system, and we're supporting it with a really joined up very senior leadership through PAM to try and make that work across primary and acute services. And then I'm sure Pam will add to that, if that's okay. Yeah.
Then just for clarity, what you're describing is a situation where much of the responsibility for the leadership of the District General Hospital now lies with the IGB and not directly with NHS Grampian because of its integration with other services within the Murray area.
Just to be really pedantic, if you don't mind, Convener, sorry. So not with the IJB, because the Integration Joint Board is indeed the board, but through the Health and Social Care Partnership, so Pam's relationship to Amanda Croft, Professor Croft, our Chief Executive, who's really sorry she couldn't be here today. So it's that relationship with support across the Murray system. And again, that's quite difficult because, you know, theatres and things aren't a delegated provision to the IJB. So it's that slightly difficult relationship to describe, but working really very productively for us to again have that really senior leadership locally. And as I say, Pam's part of our system leadership team, so I hope feels very supported from Aberdeen.
So just to clarify that, my operational responsibilities have been signed off by the IGB. So whilst it's not delegated, they have agreed the executive leadership role that I was asked to take at the end of last year. And that was because it kind of made sense that things were local and that many of the activities that were being looked at were already related to that wider system locally. I'd probably start off by saying I recognise all of those comments, and I've heard them many, many times by many, many people, and there is absolutely a perception and a belief that exists in Murray that is the case. There are alternative views. So again, you know, you kind of have to step back from that a bit and try and work out, you know, where the actual, I suppose, truth of the matter lies. I think my experience of Dr. Gray's internally, I've already said, unscheduled care, we absolutely hold our own unscheduled care. That all happens locally. You would only go to Aberdeen if you had some severe issue that absolutely you would go to Aberdeen for anyway, because we would never have that in Murray. So our frail elderly people who have found themselves in Aberdeen would be small in number, and it would be for very specific circumstances. We contain and deal with our people locally, and that's a huge part of our business. I think the aspects of the women and children's services has been a very challenging experience to pick up on. And as with the whole hospital, and actually pretty much, again, I would see as my daily job, is we have a as is and has been to what do we need for the future. And how services have operated historically, the luxury of staffing, the luxury of provision that we've had historically is very different to where we're at now. And so what has worked well, and we've talked about pensions, we've talked about our workforce, our ageing workforce, what we could configure and deliver in the past is changing. And I think for people that's hard for them to get their head round, and it's hard to see how you change because they have had a good service from Dr. Gray's and they're a very dedicated and passionate staff. You see that hugely in the fact that most people live in Murray, that work in Murray, so there's another level of commitment there. So the women and children's aspect has been extremely tricky, extremely complex, but from a public perspective, there has absolutely been a belief that this is a move to try and remove Dr. Gray's from the system, and that there isn't the investment and support for it. I think I have spoke with many of those people. I have been able to give a number of instances of investment, of no cap on overspends when there's been quite significant overspends in light of trying to deliver a good service. And of course the workforce challenge is probably the most prevalent one. We have in the last year received significant funding and additional leadership to support me in trying to address where Dr. Gray's at, and indeed to secure and be clear about how we can run things in the future for the good of the local population, but also as part of that network. So if I move to paediatrics, so we have worked through the paediatric challenge and worked with the community through a planning process, and that is now moving into an implementation phase. That has gone very well. We were given additional funds for 4 additional paediatricians into the system approved by the NHS Grampian. And because our offer is attractive, because it sits within the context of an on-call rota that is across the Grampian system, we are very confident that by February we'll have those posts recruited too. And we have an alternative model that's been consulted on, and that's going ahead. So the paediatric aspect has moved on well. The maternity one continues to be a huge challenge for us, and that is because of it's not a static landscape that you're working in. So the regulations change, the availability of staff changed, people have moved on. So in the last year, sometimes what we've been working with has changed within a week. And the situation there is at the moment we're trying to resolve particularly our challenges around anaesthetics, because anaesthetics is the backbone to a small acute hospital. So without that capacity in place, there's a number of things that would be unable to perform, and obstetrics is consultant-led obstetrics is one of them. So we are working actively on that as we speak. And then there's the question of the number of obstetricians that would be required, depending on the nature of the service that we're able to optimise to. So we are actively working on that, and we have also set up a board to oversee the transformation of services, and that's co-chaired by myself and Paul Baku, who is the medical director for acute. And we've met twice now and have looked at all the data, all the strategic needs assessment for adults, and are working through how we can prioritise those kind of vulnerable areas. But I've had significant investment from NHS Grampian to assist me in that, and we have had some really positive stories. Last week we recruited to orthopaedics, to a number of posts that we had struggled to before, and we have also had other posts within the hospital and within the partnership where we've had external interest of a significant scale in the last 6 months, and we're recruiting. So I understand actions speak louder than words, and until maternity is in a position where people feel confident, I think we will continue to be challenged on whether we're really committed or not.
Well, it's certainly good to hear a number of positives in your contribution. And in the quotes I gave earlier, I would stress that they were praising frontline staff as well, and I would echo that in my own experience. Could I just move on to the Chief Medical Officer's Advisory Group report, which I think came out last month on maternity and paediatric services at Dr. Gray's. There was 2 things I took from that. One is about need to improve communication with expectant mothers and frontline staff, and the second was to improve morale and empower staff. I think that was another bit of evidence, because that wasn't from the public, that was from the Scottish Government effectively. What work has been done to cover the 2 areas? I appreciate it was just last month this came out, but what work has been done initially to address these 2 concerns?
Yeah, we've already been trying to work very closely with staff right across the hospital in terms of where is morale, and a lot of the morale statements will be based around, have we got a hospital? Are we going to have a hospital in the future? Do we feel confident about this? So we have tried to communicate clearly the commitment. That's been presented at board level in public session to demonstrate the commitment of the board and the leadership team that we do expect a District General in Elgin going forward, but we're challenged with the shape of that and how things are delivered. The local team have been tasked with having regular meetings with their staff. We're redressing the management team in terms of the capacity. We're expanding that so that the leadership and management have got the time and space to support staff in that way. So a number of activities, so visibility of the leadership team, surveys, looking at our iMatter surveys, and really just trying to understand where we need to target and how we take that forward. So that that continues. I've forgotten the second part of your
Yeah,
question,
the two parts were communication with expectant mothers and frontline staff, and the issue about raising morale and empowering staff.
Yeah. We have spent quite considerable time with our community midwives, because the community midwives are the main contact for any expectant mum, trying to make sure that they're equipped and feel confident in their role in order to be able to work effectively with expectant mums. Obviously, the contact with their obstetrician is another touch point, but the community midwife is the main person. We also got one of our team lead community midwives to make a small film that talked through all the, tried to address all the concerns we were aware of, and that goes out on social media frequently and is on our Facebook page for mums to look at if they've any concerns.
Yeah, and thank you.
Obviously, still on the question of Dr. Grace, from a board perspective, my reflections in the last 5 years, I can fully understand where the comments that you quoted at the beginning came from. I think the whole Dr. Grace scenario for the board and for the clinicians has been a significant learning exercise on how we build that hospital to have a future in that area, but also to complement the services that come from Grampian, as I spoke about earlier, cross-boundary from Highlands as well. I think one of the main issues we have had has been about communication, and it goes to all aspects of the health board in communicating how the support for Dr. Grace would continue, because there was never ever any intention to do anything other than to make it a hospital for the future. But what we haven't done until just recently is take a decent step backwards and see what the future is, rather than try and fix the immediate problems. And I think the report that you referred to, plus other reports that we have ongoing at the current time, have allowed us to create that space that say, right, we know what's not right. Fixing that is not necessarily the way forward. What is the way forward is what does the future have to look like for those people, and to take the people with us in moving through to that new position. And I think that's the work that is now starting. We've already had some early successes, but it's going to take quite some time to persuade the people of Murray that they will have a hospital there that is of use to them, and it will be there for some time to come. But I think as a board member, I'm now more assured that we are set on a path that will get us to that, as opposed to knee-jerk reactions to individual situations.
Well, I'm sure, finally, I'm sure the public in Murray will be very gratified to hear your comments, because certainly what I was picking up was just uncertainty about the future of the hospital as a whole.
Absolutely.
And or particular aspects of care currently delivered. That's certainly an area of anxiety. And I think getting that message out to the public that it is safe in our hands, to use that quote from another context, is very important.
Thank you. Yeah.
Thank you very much. Emma Harper.
Thank you, Convener. It's a couple of questions about pain management and chronic pain management. It seems that chronic pain is one of the specialties that's been identified as a priority by the Scottish Access Collaborative, and that was created in October 2017 to sustainably improve waiting times for patients waiting for non-emergency procedures. I'm interested in issues around chronic pain management, because we've had a few submissions that were very specifically focused on access to pain management, access to consultants, issues around tramadol, gabapentin, fentanyl prescribing, face-to-face clinic visits versus telephone conversations. It seems to be a perception that telephone conversations are not necessarily the best way to support somebody with chronic pain. And there's also perceptions around whether patients are seeing the right person, whether it's a doctor versus a nurse who might be a pain specialist nurse or an allied health professional. So I guess what action is the board taking to ensure that waiting times for chronic pain is reduced, and what are you doing to help support chronic pain services provision?
Alan Gold.
Yeah, thank you very much. So first off, I'd absolutely acknowledge that chronic pain and supporting patients with chronic pain isn't at the end point yet where we want it to be. So a group we've been working with for a number of years to try and improve the provision we have. I think some of our approach is related to some of the workforce discussion we were having earlier, and about particularly our chronic pain through anaesthetics and pain specialists who are anaesthetists as well. And our volume couldn't ever be solved by just having more anaesthetists doing the work. That absolutely isn't the solution. So we've tried to think about a much bigger frame that allows actually chronic pain to be managed better and supported, rather than just that sense of everything being treated. As you'll know, that absolutely isn't the solution for a very significant number of people that suffer with chronic pain. We've put in charge one of our psychologists, so we're now thinking about that much wider frame of how we support people with chronic pain, as well as those that respond well to treatment and what have you. That's now allowing us to have a different approach that's joined up across both primary and secondary care, with that specialist bit drawing on the anaesthetic specialists and pain devices where that's appropriate, alongside supporting people to have a psychological intervention to actually learn to manage their pain much better. A terrible thing to have to face, but actually to be able to manage it when it can't be treated. So we're trying to see how we get that holistic view of chronic pain and that population who, you know, is an awful thing to face a chronic pain condition. So we've made those steps. We've appointed a few more staff to that, some physiotherapists again, to get this multidisciplinary team, and that's really starting to gather some momentum. So we're, as Alan described earlier, actually on quite a positive trajectory to make the chronic pain waiting time actually improve, if that's kind of one indice of what it is. But hopefully we're getting actually into the guts of it to support people to live with a chronic pain condition.
One of the responses was about a person who waited 10 months to see a physiotherapist. Yeah. Meanwhile, her acute pain could have been treated better with an early intervention, instead of then moving towards a 10-month wait, and then I guess a further more chronic then need. So obviously that would be a challenge to make sure we have faster access.
Absolutely, and I would apologise to that person that they did that. And again, that may have been part of the transition between some of what we were able to deliver in Murray and what we're delivering as a Grampian system. Again, there's been some transition there over a period of time. Again, just to give the context and explain that, that's from a small workforce that Pam's described pretty well already, to someone that had an interest in chronic pain who then left. And that then leaves a gap in that actually you couldn't ever recruit a person to mimic someone that's developed a small special interest as part of a much wider portfolio. So that created a bit of a lull in our ability to deal with people in the Murray area. So that's now part of a much better joined up system. But that's what you described of, rapid access to support the acute part, while we then get someone into a pathway to support them with their chronic pain, is absolutely what we're onto.
And it is interesting, there's a lot of crossover between mental health issues, pain management issues, primary care support, so that people don't get to an acute phase where we can support them. So obviously there's work that's ongoing while people are waiting to see pain management specialists. So what work has been done to help support people while they're waiting on to see a specialist then?
Yeah, there's a number of things. I don't know if someone wants to...
Yeah.
Sandra?
Yeah. So as part of our primary care improvement plan, we're looking to have first contact practitioners in each of our GP practices, which again will be able to be, GPs can refer or can be signposted, so to start some wellbeing activity, to start some early intervention work while they're waiting. I think there is a number of projects, as Adam describes, ongoing, where we're linking with public health as well, just to really give that much more holistic view about managing people's chronic pain, as well as the treatment and interventions. So there's a range of things that are already taking place. Okay.
I think, just as Sandra's saying, I think the GPs would tell you that they probably handle the majority of chronic pain in primary care. And actually a plea from them around the support around them is an important one. I'm actually meeting with the Murray Pain Group in January, so that'll be interesting to follow up with them. I think we are, though, within the primary care improvement arena and within our health and wellbeing arena, really, again, needing to think a bit differently about the workforce that's available to us and the wider workforce who can contribute to this. And a conversation that we will be looking to take forward with our GP advisory group and others will be that very thing, that we haven't got sufficient physios to
cover every post that we are creating here, is there a different way to consider our leisure estate in terms of PTs and trained trainers who can do early intervention and prevention around MSK. So we're very keen to pursue that conversation, because I think more and more we have to think beyond, again, the traditional workforce. Who else can be the team that supports that population at a local level, keeping as many people away from, not away from specialists, but only really the really complex cases requiring that specialist intervention.
Okay. I suppose I should talk about GPs. They are the ones that are looking after most patients right up front. So as far as primary care, one of the other submissions was about somebody who couldn't get a GP appointment for 4 weeks. And I'm wondering if GP appointment models are fit for what we need for people. You know, people have various shift patterns, working times. You know, some people might not be able to get to a GP appointment till 5, 6, 7 o'clock at night. So, and I know different models are being tried in other parts of Scotland where they'll have early opportunity, or like before 7 o'clock, for instance. So is there work being done to look at how the IGBs or the board can help support GPs to have a different approach to appointment access?
Yeah, I think that's all part of the whole piece of work that we're involved in, both in and out of hours. So our out of hours general medical service has also got real challenges, again workforce based. And so what is the opportunities with technology? We have got in Grampian in every GP surgery now the Attend Anywhere e-consult capability. However, putting that in without any business change and consideration about who and how you use that would be remiss. So there are pieces of work going on with certain surgeries at the moment where they're indeed learning about where that has best value, and again that offers a flexibility going forward that might make a difference to how we operate and work our opening times. We haven't got solutions to all of that yet, but I think those are the very things that we're trying to work through as part of when do you need to see a GP, when can we use a wider workforce, and when can we use technology. So all of that we would hope to see a different level of responsiveness over time, although for some people there isn't a requirement for immediate response, and so different practices have got different ways in which they manage that.
Okay.
Sandra Ross.
I'd just really like to build on what Pam's saying. I think it is as much about a 4-week waiting time. It is about the triage model, and there is a lot of spoke on earlier about know who to turn to, our campaign, and it is about that, using the whole system from pharmacy, using through to other practitioners, using through for other areas, and really focusing on that prevention and the self-management. So things like bringing in technology such as Attend Anywhere, looking at really positive triage models and using our wider team will certainly help improve that. But taking on board your point about looking at flexible working across 7 days early, and there's other solutions that will help to take that forward.
Okay.
NHS 24 have obviously done tried a really good model with Riverside and Musselburgh, and we're looking to learn from that as well to see how we could build on their experience.
Adam Crover.
Thank you very much. Just a slightly wider point I'd really like to add around the GP challenge that you described, that we reflect for appointments. So a key part of our clinical strategy is thinking about unscheduled care, planned care, self-management and prevention. And the thrust of the clinical strategy is how do we move stuff from unscheduled to planned to self-managed, and how do we prevent both primary, secondary, tertiary disease, whatever, through everything. And I think the self-management bit's absolutely key to changing the relationship between patients and statutory provision of service, if that's reflected through GPs or nurses or anyone in a primary or secondary care team, or indeed across a social care team. And so, we've got, you've seen in the pack, we're really pushing forward the House of Care as a model. So again, trying to change the paradigm of consulting, where the patient has a much, much higher level of responsibility and ability to interact with the healthcare team, so that they actually then manage their condition very differently and much better. And if we remember in our population the amount of people with chronic disease who access primary care, it's absolutely, I can't quite remember the number I'd say it, but it's a really big proportion is chronic disease driven. So again, the more we support people to self-manage, we're hoping that that paradigm shifts and actually the demand for that, you know, day-to-day appointments with a doctor in particular does change over time. So that's, and I think we're trying to do both the sort of descriptions of how do people access it, because that's, till we've got the other system really working, that's not okay. So it's that, but that our bigger model and the picture we're trying to paint is this shift of activity down that continuum, and self-management is an absolute key to success in the future.
Okay. GP contract. In my South Scotland region, some criticism on the GP contract was put forward by rural GPs, and obviously it's a rural region, Grampian. So how is the GP contract, which is negotiated by the BME and the Scottish Government, how is it working in NHS Grampian?
And you would?
I've been involved a lot around the introduction of the new contract, and I think where we have had real success is around our collaboration and our discussions with local GP sub and with engagement with the practices. So I think you're absolutely right, and I would say that there was those same concerns raised and continue to be raised across some of our practices. But I think what we have done is to look at the memorandum of understanding and to try to think, well, how do we develop those services within our area? So we are very lucky across all the partnerships to have really strong clinical leadership from the GPs and from the practices within our management teams, taking that forward. And again, I think the relationships we have with the Grampian GP subcommittee, who are obviously the BMA representatives within the area, has allowed us to really explore what our options are. So I think it's that ongoing engagement. It's tests the change, because actually sometimes what we did is we've just got on with things, and hopefully we will learn from that. And sometimes, again, because of the way the three partnerships work together, we can test things out in one area and then see what the learning would be for other areas. So I think it's that constant checking in that I think we're working so closely together. I think the other thing that we've been really upfront about is the impact on the whole system. So yes, we could go out and advertise a whole heap of jobs in one area, but actually what would that do to the whole system, and what would that mean for the patients who are receiving services from that? So I wouldn't say that it's been without challenge, because it hasn't, but I think we've seen some real good successes, and I think as Pam described there, you could say, well, the model is around physios, so therefore that's the only thing we'll develop. But actually we're very quickly saying, well, actually maybe we've got other resources that we could use in different ways. So hopefully that will continue to take us forward.
Okay. Pamela Jurek.
Just to give some assurance, Angie and I both sit around the National Rural Group and have been around all the conversations there, so we're well tapped into that. We recently, probably about 3 months ago, had our visit from the government team, which included all the clinical leads, all the leads for primary care in the three partnerships, primary care contracts, who I host on behalf of NHS Grampian and the three partnerships, and our LMC rep and GP sub reps, and we were complimented on the way that we work together. And actually, sort of, I suppose, an endorsement for us as a management team was that our LMC rep and GP subset rep were very complimentary about their relationship with us and where we got to unstimulated. So that was reassuring for me that our relationship's in the right place, and whilst we have many challenges, that we are having the right conversations.
And we know the GP contract is about a multidisciplinary team approach in primary care.
Yes.
And evidence or witnesses that have presented here have basically said we need a national engagement plan to teach folk about who it is you need to see. Maybe it's a physio, maybe it's a dietitian, maybe it's a different member of the team. So is there any work that the board are taking forward to show that the GP contract is including a multidisciplinary team, and how would you support that in primary care? So I guess the question is, have you done any work to help educate the public about changes that are happening in healthcare?
I think we find it quite difficult, sorry, to think about things in isolation, because the whole integration agenda is a mirror of what we need to do with the primary care contract. So I know there's a lot of debate about some national messages, and perhaps there's no harm in that, but I think my experience of working with localities around understanding working with the population to understand what's available in that locality and how you start to navigate it really probably is the best way to get people functioning well within their area. And because the resources are different, so you configure on what you have sometimes. And actually the public have got some great ideas. So if I were to go consider Forres as an example, where we decommissioned the community hospital with the community, quite a difficult thing to do, but we continue to work with them around our evolving model. The community council work with their community around the messaging in that, and we're looking at working up a community asset transfer with them, but in terms of what does that mean for health and wellbeing. So I think working with the community is much more powerful and meaningful than perhaps just a national campaign, although I'm not saying that wouldn't add some weight.
Okay.
Very much. Sandra Ross.
Just to add to that, the whole area about working within your community, we are firmly based within our local outcome improvement plans, working with our community planning partners, and I think they have a significant role to play in primary care as well. I think some of that messaging that Pam describes really gets taken across there from we're working with those partners as well.
Okay, thank you very much. Brian Whittle.
Good morning to the panel. My interest really lies heavily around the preventable agenda, and that's been mentioned a number of times today. And specifically, if we look at what I would say is an epidemic around obesity and the impact that obesity has in so many other conditions like type 2 diabetes and COPD and heart disease and MSK and mental health. And what I was, before we start the rest of the questioning, I think that what we should be doing is looking at those who look after us. And there's a lot of evidence to say that frontline staff are actually less healthy than those they're trying to treat. And then we were talking earlier on about retirement age, the impact that sort of ill health can have in retirement age and absenteeism. So I think my first question around this would be, how are you tackling that? How are you going to create an environment where your healthcare professionals can have a healthy, active lifestyle, have the opportunity to have a healthy, active lifestyle?
If I could start, that would be great, and I think everyone will have something to say on this. So, the Director of Public Health's annual report was on obesity this year, obesity and activity, and that was presented to RONA's board just last month. This month. It is still December. This month, yes, this month. So, and that is setting the context for Grampian. So, two out of 3 of our adult population are overweight or obese. And there's a real challenge with people understanding their own level of weight and healthy weight. So there's a real community-wide challenge, and lots of the Director of Public Health's report talks about how do we start to, I guess, get in about that, and lots of the stigma and all the sorts of challenges we've got about people having a healthy weight. In terms of your reference to the staff, that's one of the key things we've identified in our clinical strategy. So that we published our clinical strategy a couple of years ago, and we have those 4 blocks that I described: unscheduled to plan, to self-manage, to prevention, and we have a number of cross-cutting themes. And one of the cross-cutting themes, the things that enable us to deliver the strategy, is about our staff, and it's about our staff well-being, including them having healthy weight, not smoking, drinking sensibly, exercising. We have, in terms of supporting our staff to be able to have those good aspects of a healthy life, all of the stuff you'd expect around healthy working lives. So we have NHS Grampian registers healthy working lives, and each of the partnerships pursue healthy working lives, again to try and capture the real breadth of their staff, because obviously they have all sorts of council staff as well. So we've approached it in that system. We have people at some at gold, some at bronze, and building up to gold. So there's that very sort of system-wide approach towards healthy work. We're doing quite a lot in different management teams around well-being and mental well-being and how people are able to be, I think we've moved on from trying to describe people as being resilient to how do you thrive in a really challenging environment. So a sense that delivering health or social care will ever be easy, it is probably not. And we're trying to move from that idea of resilience to, as I say, thriving in challenging situations. So all of that, it kind of comes together as a package about how we do it. Now, we're really, really clear. We haven't fixed it, we haven't got the ultimate solution, but it's really, really high on the system leadership team agenda. And we're wrapping that well-being into culture and how we support people to have a really positive place to work. So positive workplace is largely about behaviour and about how we all behave when we're in an environment. So we've got a systematic approach to a programme rolling out that whole sense of culture and really positive culture. So we're as I say, we don't think we've kind of fixed it at all, but we're really conscious we've got a number of building blocks that are going to help our staff to do that. And also around obesity, just to kind of finish that a little bit, it's one of the very challenging conversations for a health professional to actually talk about someone's obesity with them. And again, when they're trying to build trust in a consulting relationship, to bring that in is one of the most commonly reported challenges. So again, we've got some programs of work supporting people to have those challenging conversations. And indeed, Catherine Calderwood's just published something about that realistic medicine, and part of it is about that consulting method, which will help people to have conversations about people's weight as well in a much more productive way. Sorry, that was a very long answer. I do apologise.
Sorry.
This might seem some of these things I'm going to say seem quite small, but the impact is significant. In Grampian, we do a lot about quality improvement. And I was recently up in Elgin seeing the last cohort that completed the course in quality improvement. And the one project that really appealed to everybody and had been successful was the one where nurses in one ward took on the initiative to persuade all the very caring and kind families who brought in chocolates to say thank you to change it to fruit. Because if there's chocolates there, you're going to eat them. It's just a given. Yeah. But they gave it to fruit, and then the patient started to eat more fruit as well. And there were other signs of where that was beneficial, so it was that. There's also been a great spread of values-based reflective practice. Now, that doesn't directly take you to obesity, which was your question, but it's about the teams getting together at the end of a particularly hard shift and finding a way to talk their way through it and to care for each other so that when you go home, you're not taking that burden home with you, and therefore you don't do something unhealthy. You're in a better state of mind when you leave. The organisation as a whole is going for magnet accreditation. That's largely through the nursing workforce, but it applies to everybody. And again, that's about teams taking responsibility for themselves. We're very clear in Grampian that if we're going to get culture change, we can't do it to them. They've got to come with us and do some changes themselves. So the magnet is helping them do that. So they're gaining power to control their own environment, nursing teams, about how they raise money and how they spend money and how they help each other to be the better teams that they are. So they're all very small things, and there's no great corporate drive for it all to happen. But the more you give people the power to help themselves, the more that they do. Thank you.
I'm glad you talked about cultural shift or cultural change, because I think that's ultimately, where we have to be as a society, let alone. But what I think I was interested in is how we're going to lead that from a healthcare professional's perspective. You're talking about how difficult it is for a healthcare professional to start that conversation with somebody in a surgery. How do you start that conversation with a healthcare professional? Probably more importantly, how do we stop people being obese in the first instance? And second, the last part of that question is, how are you measuring the impact of the change?
I suppose I could give a small example about that. We've recently had a survey that's been undertaken with we're looking at our strategic planning for care of older people. But actually, as a large part of that survey, what we did was focus on people who are not yet, who are working age and who are coming up to older. And what we found was that a large percentage of people who had replied to it But fundamentally, the messages are getting across. People know about healthy diet, they know what they should be doing, and they know, you know, how much exercise, and know what the healthy diet is. The problem that's stopping them is it's making it easy. So we've already started some conversations with our Joint Staff Forum about saying, so how can we, as an employer, if you like, how can we as a as NHS, as IGB, as partnerships, start to make it easier for our staff to make healthier choices. Simple things like Rona's describing about the fruit, but also how do we get exercise built in? How do we get breaks? How do we make it easier for people to have an active lifestyle? We're also looking at I think newly on Tourists is about having the right conversations and helping people to have those early conversations and us to have those with staff. So,
can I just move on slightly from that? I think we're talking about, I think, Alan Gray, you mentioned earlier on about, for example, the rise in the cost to the Health Board of prescriptions.
Yeah.
And you know, I think it's my belief currently that if we don't change the trajectory and the strategy in which we're doing with health, and we don't shift it towards the cultural shift that we're talking about just now, I think the burden and the strain on the health service will become intolerable. In terms of, you know, a very specific example you gave about rising prescriptions, we had a lot of very, very compelling evidence around the importance of social prescribing as instead of you know, prescription of medication. So where are you in terms of utilising that third sector organisation that we talked about before, in terms of utilising social prescribing as opposed to medicalising problems at the moment?
Yeah. Okay. Start. So the social prescribing is a really big shift. We've been down to within the city, within the partnership, and I think as part of our wider system, we've been down to look at what's happening south of the border, down in England. I think they're quite well progressed with a lot of social prescribing. The other areas that we're looking at is round about how our primary care improvement plan, how we can start to look at that for social prescribing, and in addition, really just. So I've forgotten what I was going to say there. Sorry, it's went blank. But I think the social prescribing component for us is quite significant, moving with our third sector. Sorry, I just totally went out of my head.
Come back.
No, it'll come back to me.
We're nearly done. Angie Wood.
I suppose it's perhaps a slightly different topic, but I've certainly noticed the discussions that go around the community planning partnerships have changed. So recently the Director of Public Health came to speak to the board, the CPP board, and I think there is a definite shift in a view that these are no longer necessarily things that need to be treated, but can be things that can be prevented. And actually the prevention agenda doesn't just sit within the health service or within the health and social care partnership, but actually in wider society. So to have discussions with the leisure industry, for example, you know, that's a really interesting industry in the northeast. It attracts an awful lot of people, but perhaps some of it is not the most healthy that could be there. So I think a real challenge, I think, to our partners to say, well, you know, what's our role within this, but what's that wider society role as well. So I think that is an interesting change that we're seeing.
We've recommended as a committee that IGB should work towards 5% of budget on social prescribing. Do you have a sense of where you stand now and how achievable that might be? Sandra Ross.
Sorry, it came back to me what I was going to say. Yeah, actually links into that. I think I wouldn't at this moment have a percentage about the percentage time, but what I would say is that much more we're looking at our commissioning approach to being far more about user-led, about people who are using the service, about integrating that within, and for example, within traditionally daycare activities have been that somebody goes along, they receive daycare and they come home at night, but much more involved in our third sector, our sport, our leisure, and giving people the independence through SDS to access those services and make that much more about using their own, instead of prescribing, to people being able to access and therefore do early intervention and prevention agenda. So tying it all in.
We've recently revisited what the percentage was in our IGB on the basis of a report done by our Director of Public Health about 3-4 years ago, and it was about 4%. So we're looking, just as you said, to build on that. But I think, you know, there's not always a direct clarity between what happens in a GP practice and the kind of social prescribing that's going on under a different banner across our communities. And we've done a huge number of activities, as others have, like vintage tea parties, boogie in the bar, our ball groups, which are all underpinned by health promotion support and conversations about being active, making good life choices. So there's actually a huge number of activities going across all our communities every week that actually constitute that. I think our leisure people are going to hold us to account as much as the third sector as well, and I think that's the beauty of community planning and IGBs, where you have that wider partnership who will say, you know, that's not good enough, we could contribute more if you work with us. So.
And
just a point that Rex made a bit around the fact that there's no one single silver bullet. There's lots of little things that will contribute together to build towards that shift. And one of the things that kind of strikes me is that, you know, if we talk about the real preventative at the very start, one of the things that can prevent children becoming obese or developing obesity in later life is being breastfed when they're, you know, when they're younger. So how are we promoting that? Is that something you're trying to push? Where are we in that sort of scale at the moment?
Adam Coleman.
Happy to do that. Yeah, happy to do that. Yeah. We've. Now I might be getting confused between Aberdeenshire and Grampian here, but so forgive me. So we have the UNICEF award for can't quite remember what it's called, but it includes breastfeeding and how we support not just young mums, new mums to breastfeed and to maximise people's ability to breastfeed. So that's one of the really key things we've got to approach. And again, we're moving to you know, the best start and the new midwifery model. So we had a really fantastic presentation the other day from a midwife who's now working across the system. So it's that sense of continuity for a mother in the community, actually during labour, and then back into the community afterwards. So that continuity of care that makes a difference, and that has a really big increase in a number of very positive measures, including the likelihood of people being successful at breastfeeding, both I think in terms of confidence in their professional, but also the support that they get with someone they know and they have a relationship with. So that's now rolling out. It's happened in a couple of patches in the city, and someone up in Murray. I think Aberdeenshire on the list to start to do that with their midwives. So that will be our midwifery model, and that will, we believe, make a difference to all sorts of things about people's and children's initial bit of birth, and also the mothers, and therefore that whole relationship about a really good early start to life. As well as all sorts of programmes. Angie made reference to working differently with schools and all sorts of things, which is then builds through people's early lives as well.
Thank you very much. And finally, David Stewart.
Thank you, Convener. Can I move to technology and digital? Could the panel perhaps provide some examples of best practice within your health board area and the areas of technology and digital?
Sandra's our tech thrasher, so
I suppose our most recent that we've worked with, the area of technology is still quite it's a difficult one. It depends whether we're talking about technology-enabled care, which is devices, and how we're progressing with that, or whether we're progressing with the whole digital agenda and whereby we can work as a whole joined-up collaborative system. I think with the part about us working as a whole joined-up collaborative system, there's work to do not only at a Grampian but also at a national level to help support that agenda. I think that's something that we would be keen to support progress on. But at a more local level, we're certainly working closely. Recently, we've moved our health visitors forward with using Morse, Cambric Morse, which is something that 5 of the other health boards have in place to get their records digitalised. So within 5 years, all of our children within the city and the Shire and Moray probably are following on, will have all our records will be digitalised. We're part of an early adopter programme for tech for systems for recording people with abuse, and we're also have some recent issues with the ARMED programme, which is whereby I think recently they've tested that out in some areas and had a falls reduction to 0, so we're testing that out just now. But I would say that the patient record is the big one that's...
And if I could...
Adam Cooper. Sorry, David. Adam Cooper.
Thanks, Committee. Yeah, so just a slightly kind of wider pitch, if I might give us the context, perhaps I should have done that to start with. So in terms of almost everything to make a difference is about this single digital record. That is the fundamental building block, and we're moving closer and closer to that being an absolute reality for people. And again, there's all sorts of work, and we're trialling some stuff about a full integrated health and social care record. So across the whole health and social care team, people can see and absolutely hear the word appropriate, but appropriate data from every professional that's involved in the care and support of an individual. So that's the fundamental building block. And then Simon's given a couple of very good examples from primary care and secondary care. We're just doing some work with asynchronous consulting in outpatients. So that basically means that if we've got a consulting relationship, I establish with you certain data that you need. You have a role to tell me what that is. I then, not in real time, am able to then explore with you what your things, and works very well for lots of chronic conditions. And that looks to produce something like between a 30 to 50% efficiency in consulting time, not consulting time, but the role of the typically doctor. This is a doctor consulting time. So again, around that huge outpatient challenge that Alan's described great progress on, some of the technology we believe will enable us to make a real difference about how we can support the volume of people that are in the system to have much better through that sort of technology. So there's that. And then our other really, I guess, exciting thing to make just slightly wider than digital technology is we've got a small team of people that lead on innovation, and this sense of how do you change a paradigm in innovation. So whether that's us asking the innovators to fix a long-stayed problem, so that's a slightly different approach rather than just innovators telling you what you might do. So we're gathering some real momentum with them, and they're the guys that have brought forward this. It actually works through an app, doesn't kind of matter, but an app around dermatology and how people are supported to consult with that. And we're really quite excited about reporting on that and sharing that across the country. It looks extraordinarily promising, but it's still at that very early stage of doing it, but real, if you sort of mean.
I think that's realistic. Could I just probably finally, I know time's tight, convener, is talk about technology to try and fight the tyranny of distance. You've got 3,000 square miles in your board area, a huge area. Yeah. We've also want to tie in the issue of regionalisation and how you collaborate with other boards. So let me give you one example. I've got a local campaign in Highland, my own area, to have a PET scanner, a positron emission tomography scanner, for those who were off school that day, which obviously, if it was successful in Inverness, would provide scanning for the bulk of Murray, which we talked about earlier, about Murray. So rather than a board on its own say this is a good idea for our 400 patients who have to travel to Aberdeen, Dundee, Edinburgh and Glasgow, if this was collaboration with your board, you could benefit. I would imagine the bulk of Murray would be better going to Inverness than Aberdeen. I have to quite look at my geography. So is that sort of conversations you've had with neighbouring boards? Because
we've actually just published our regional asset management plan. So we have an asset management plan for the whole region, David. So in terms of what you're just saying, the combination of our asset management plans across Highland, Orkney, Western Isles, Tayside and Grampian, we have now a combined plan. We're working to see where the opportunities are to work together on some of these investments around diagnostics, use of our hospitals, the whole digital strategy. So I'm hoping that you'll see that evolve over time, but we've now got that combined. That was published by Grampian, went to the Grampian board in December. It's been approved by the Chief Executive. So I guess we've got absolute commitment, David, to work together to maximise the use of resources and investments in infrastructure and assets across the north of Scotland. So yeah, you're absolutely right. I think we'll aim to do that and to build on that in the coming years.
Right, thank you.
Brief supplementary from Brian Whittle.
Thank you, Convener. One of the things, this is not a technology problem, I think, within healthcare. I think there's, having come out of healthcare tech myself, I think there's so much really good technology out there that isn't being currently utilised. So it's adoption of technology is the problem, and there's so many great pilots gathering dust on shelves. So I think the question then is, how do we take that technology and how do we give frontline staff the time to adopt and to personally develop so that we can cascade this technology into the front line.
If I could start, so I'd agree with that, and it wouldn't just be exclusive to technology, it'd be to all sorts of good and best practice. So we've been giving a bit of thought, we haven't solved it yet, we've been giving a bit of thought to the gap between good proof of concept and tests of things working, pilots, and rolling out at scale. And there's I think the best simile is really taken for me from Dragon's Den and the development of the curry sauce. And developing curry sauce in your kitchen is one thing, but to make it commercially, you don't just do it you don't just get bigger saucepans and bigger burners. You actually have to completely reconstruct the ingredients, because doing something at scale is fundamentally different to doing it at a small test and pilot basis. And I think the reason healthcare struggles to do stuff at scale is because it thinks you just do it with bigger saucepans, if you see what I mean, and you fundamentally don't. So, interestingly, I made reference to the innovation team. That's one of the things we've tasked them with, is to think about what is that transformation model we need to say we've got a fantastic example of something working in one specialty or one practice or one team. How do you actually do that? Because again, when we develop stuff, you put a ton of resource and interest, and people are developing the wheel, which is the exciting bit. When you're then told this wheel's a really great thing to do, actually you don't have that same investment and personal buy-in. So we need to reconstruct how we make things happen at scale. And I would be delighted to share that with you when we fix that with the innovation team, because it's a common problem to lots and lots of problems that we observe and get really, really frustrated by.
Thank you very much. And I guess that's a cue for me to say that we will, I'm sure, come back to you with some further information as required once we've had a discussion about the evidence today. I think it's been very striking today how far the Health Board and the 3 health and social care partnerships are approaching matters with a shared approach. Would it be fair to say very briefly that level of integration and that joint approach is something that's supported by the Health Board, obviously, but also by the 3 local authorities in your areas? Is that something you would agree? Rona.
Very, very briefly, in covering for the chair at the moment, I attend the NHS chairs meetings once a month, and integration is quite a regular topic. And I think hearing what they say about their scenarios compared to what we're experiencing in Grampian, we do have that integration across all the partners that seems to be quite unique. There are some other places, we're not the only place, but it is much better established and starting to move forward rather than talking about how it should be in Grampian than I'm picking up from other areas.
Thank you very much. And can I thank the witnesses for a very full evidence session. We will now suspend briefly to allow the witnesses to leave and then resume in private session in 2 minutes' time. Thank you very much.